start. All right. Well, good afternoon, everyone. Thank you for joining us today. My name is Renee. I'm the Education Manager at the Michigan Center for Rural Health. The Michigan Center for Rural Health is a nonprofit state office for rural health, and a cornerstone of our office is providing free education to rural healthcare providers. I'll be the facilitator of this program, and I would like to welcome everyone today to today's Psychiatry Grand Rounds. This activity provides one contact hour for social work, community health workers, and physicians can self-claim the hours. As well as I would like to introduce Adrienne Wilkerson from MSU College of Nursing to continue with the professional development information.
Thank you, Renee. So as Renee said, this activity is also providing one contact hour of nursing continuing education credit. Our provider statement is listed on the screen for you to read. I won't read through it, but you can go to the next slide. So completion criteria and financial disclosures. The criteria for successful completion today is that you're participating in the learning activity and that you complete that post-session evaluation survey at the conclusion of the session. We ask that you please complete that survey at the session ending point, if at all possible. It just helps us to stay on track to close out our events in a timely manner. We understand that not everybody can do that immediately, so it'll still be open for a day or two, but just to complete it if you can right away would be helpful. And for commercial and financial disclosures, no one with the ability to control content of the activity has a relevant financial relationship with an ineligible company to disclose, and there are no commercial interests associated with today's activity to disclose either. And then your learning outcome for today is that upon completion of the activity, we hope that you'll have increased knowledge of the impact of pain in children and how to address it in rural Michigan communities. And I'll hand it back to Renee.
Thank you, Adrienne. And then we'll have the post-session evaluation up at the end with our QR code, and also we'll drop it in the chat. With that, I'd like to introduce our presenter today, Natasha Cunningham. Dr. Cunningham is a pediatric psychologist and tenure-track faculty member in the Department of Family Medicine who is committed to improving psychological care for children with chronic and painful conditions. She is currently testing the implementation of a training program for school providers to manage pediatric pain in Michigan schools. She also conducts neuroimaging research to understand the impact of psychological treatments for pediatric chronic pain and clinical trials of psychological treatments to improve mental health and health-related outcomes for children with chronic and painful conditions. Examples: lupus and abdominal pain in medical settings. Thank you so much, Dr. Cunningham, for being here today. We truly appreciate it, and as do our rural healthcare providers. With that, I will go ahead and stop sharing my screen and let you share.
Wonderful. I really appreciate the opportunity to be here today, and I hope everyone can hear me okay. Great. I'll go ahead and share my screen with you. And let me just maximize this. And it's just wonderful to see such a wide audience of individuals, and I do hope this presentation will be useful to you, and really happy to have this be the start of a continued dialogue. So please feel free to reach out to me at any point. If you have questions during the presentation, feel free to enter them into the chat, or somebody's asking about reviewing the CEU procedure since the audio might not have been working. I don't know if
Renee... Yep, sure. Thank you. So, yep, as long as you have registered, which you did so if you're on here, hopefully, and then attending the session, and then we will have a QR code and drop a link in the chat at the end of the presentation, as well as you will receive a follow-up email with all of this information as well. Thank you.
Everyone can see the slides okay, I assume? Great. Okay, there's a really comprehensive team of individuals, including researchers and community partners who engaged in this work. So I just want to acknowledge some of them here. And these are my affiliations and disclosures. I am actively funded by the Michigan Health Endowment Fund and the Blue Cross Blue Shield Foundation of Michigan for this current program of research. And I have some other current funding sources as well, but no other disclosures. So something I really like to first kind of talk with people very candidly about that we don't always think about is that chronic pain is something that is really common and debilitating in children. Many people assume this is an issue of older people. I know me as like now a middle-aged person deal with some level of chronic lower back pain, for example, and we don't always think about the impact and how common this is in kids. But in fact, about 10 to 20% of all children deal with chronic recurrent pain. And these are the kids who are more at risk for developing conditions such as anxiety, depression. They're also more likely, due to increased school absences, they miss on average about 1 in 5 school days. And so they're actually at risk for failure to graduate and just have additional academic impairment related to kind of missed school and difficulty attending when they are in school cognitively. So it's a real problem. The other issue for kids who have chronic pain is they're more at risk for using and abusing opioids as they age. There's been studies showing kids with chronic pain are at increased risk for opioid misuse in adulthood. So I think we really are tasked with preventing that trajectory by getting good evidence-based strategies to help children manage their pain in place, particularly in rural communities where there may not be access to primary care or behavioral health providers. And so really, when I came to Michigan State University, I came from Cincinnati Children's, and I was working in a really leading, lovely subspecialty medical center that only really a privileged few had access to. So children with chronic pain who came in to get treatment from a pain psychologist were generally of upper SES from families that had resources to kind of get them through the door at this clinic. And one of the reasons that really drew me to Michigan State University was the opportunity to partner with community members to get evidence-based strategy into the hands of kids who need it, particularly in rural and underserved communities in terms of access to healthcare. And I really have been finding and learned from colleagues at Michigan State University and in my work that it's partnership between people like myself, kind of the traditional researchers, and community members that really help increase access to care. So again, this is such a common problem. And when we think about, not everyone has access to a pain psychologist. And when we think about who are the people who see these kids, school nurses are often the frontline providers who are tasked with managing kids with various pain complaints, acute pain, chronic pain, pain due to an organic disease. And in fact, 1/3 of all school nurse visits are for pain conditions. Now, school nurses are the frontline providers, but they do not generally have training in causes of and treatments for recurrent chronic pain in kids in terms of non-pharmacologic evidence-based strategies. Then if we think about the state of Michigan, not all schools have school nurses. So in those instances, it may be an office assistant who might be the first point of contact for these kids, who the kid is going to if they want to go home, for example, due to kind of symptomatology that's getting in the way. Or they may actually work with a mental health specialist. And while some of them do have training in kind of cognitive behavioral strategies for management of mental health issues, they may not have had training into how to apply those strategies and tailor them for kids who are suffering with pain complaints. So I started this work several years ago, and I have family ties to the northern Michigan region. So that was really an area very close to my heart where I was intimately aware of there's no pain psychologist in Northwest Michigan. If children want to see a pediatric pain psychologist, they have to drive to Helen DeVos Children's Hospital in Grand Rapids and see the provider there. And that's just not a feasible approach to get kids access to care. And something else really important to consider is even though a lot of providers now offer kind of virtual options for care, access is still really limited for people in rural communities because a lot of the people in the community where the care is offered who have the resources to advocate for that care and know about that care are often the first ones in line to receive it. So there's still a bottleneck in terms of getting people access, even though there's been more increasing use of virtual therapies kind of following the COVID-19 pandemic. So when and I have family ties, and I was so excited to be in Michigan and partner with community members to do this work. And what I have learned and what I'm continuing to learn is it takes time to build a culture of trust as an outsider who's not presently part of that community. So the initial work I did was really in the spirit of kind of partnering with the community to understand the need and co-developing solutions to help, leveraging my expertise in pediatric pain, but leveraging the expertise of the people on the ground working with these kids in terms of what would be a feasible approach to increasing access to care. So I partnered with the Health Department of Northwest Michigan. And the health department has been in the news. There's been, a lot of political controversy. And what I will say is the people that I have been working with within that health department are really fierce advocates for the needs of kids. And I kind of naively assumed that, helping kids who are struggling with chronic pain is a nonpartisan issue. But I mean, everything can become somewhat impacted by political climate. And so I do recognize and appreciate those are also some challenges in terms of increasing access to care, just to be aware of, and that we kind of grappled with in these recent years. But we were able to really form a very robust partnership. And the people that I worked with really saw the utility in this. And it was in understanding their needs that we were able to kind of move forward in launching a training program. But before we did that, I first just kind of to understand some of the statistics. These are publicly available statistics looking at kind of gaps in access to care. And in fact, we know this statistically, the number of available behavioral health care providers in these counties are extremely low. So we know about 10 to 20% of all kids struggle with chronic pain. And you can see here the numbers. In a good scenario, there's one provider to 300 people. And the access to primary care is equally scarce. So we're really in an area where there's a bit of a desert in terms of access to someone you could refer a child to go and receive this care. So just to pull out some additional statistics in Emmett County specifically, we have seen data publicly available that, again, about 12% of all individuals report frequent physical distress. So that could include pain complaints. There's that scarcity of primary care providers. And then there's a number of children living in poverty, a larger number, about 21% living in single parent households, some children with lack of access to insurance, and 1 in 10 of all children do not graduate from high school. And that's really important in terms of from a pain management perspective, because I do think some of the kids who are struggling with pain are at increased risk to fail to graduate. And so I think this is a place where we can potentially have an impact and hopefully increase graduation rates by providing access to evidence-based care to keep kids in school. There's also statistics about preventable hospital stays, and we do see a lot of kids with chronic pain. Sometimes instead of going to a primary care provider, which they may not have access to, they may go to the emergency department to rule out potentially organic conditions or for pain-related management, pharmacologically speaking. And some of that may be unnecessary and not indicated. And so that's another potential area where we can have a long-term impact in terms of changing some of those practice patterns. And so really that's the goal of the work that I'm doing, is to try to increase access to effective non-pharmacologic methods for managing pain. So it starts with building relationships. And so I mentioned this partnership with the Health Department of Northwest Michigan. I also have a partnership with the Michigan Association of School Nurses. So it's allowed me to take a statewide approach in training people through that latter partnership, and then a focused approach in Northwest Michigan in partnership with the staff who are employed by the health department and serve schools. So in the first year, I just assessed interest from the leadership of those two organizations. They indicated some interest in this work. And so I did an introductory seminar with separately with the Michigan Association of School Nurses and with the health department. And so there was a mix. This was primarily delivered to school nurses, but also some mental health professionals serving schools. And we broke out kind of the specific people who received this within the health department. And so this is what the introductory seminar, the data we captured. We just wanted to know kind of feasibility and self-reported knowledge of CBT strategies for managing student pain. Just some simple measures, and we also got just some indices of interest and additional training going forward. And so CBT for pain, I mean, so my training, I have a PhD in pediatric psychology, and then I did a 3-year intensive fellowship in pain management approaches. And then I was an active clinician as a part of my role as a full-time researcher, supporting the needs of kids with chronic pain. So all that to say, there is a lot of content that goes into kind of delivering pain-focused care. But this was really, the purpose of this was just what can be distilled so that people can start to understand what it is and see if it can be useful to the children they serve. So I did about a half an hour on just kind of explaining about the definition and prevalence of chronic pain in kids, and something we call the biopsychosocial model of pain, which is how biological factors, psychological factors, and social factors might kind of influence and impact kind of pain presentation and functioning in kids. Talked a little bit about how one might assess for pain using kind of numeric pain scales and also measures that report impairment due to pain. And then just gave a very brief overview of some simple cognitive behavioral strategies that can be effective for addressing pain, psychoeducational strategies, a few behavioral strategies, and some cognitive strategies that can be used. So again, this was 2.5 hours total. So a very brief kind of introductory overview. And what we found in doing this is people's self-reported knowledge of understanding biopsychosocial risk factors, understanding the evidence for using CBT, and at least feeling comfortable discussing CBT with students significantly increased. And again, this is self-reported knowledge, so it's also really important to test kind of objective knowledge measures. But I think what this showed us initially is a positive signal that, in fact, there is some increased understanding that can be delivered in a brief kind of educational format for people, and they can start to feel more comfortable addressing these strategies. But I think there's still room to grow as well. The other thing that really supported kind of doing additional work was just after this initial introductory seminar, the vast majority of people agreed that it was helpful. 98% agreed it was helpful, and nearly 90% of the people who received the seminar wanted additional training in using CBT for pediatric pain management. So we now had the buy-in from the community members that this was something that the majority of people found could be potentially helpful in their own care of these children. So then over the past year, I worked with the leadership team and a few champions to actually co-develop a comprehensive training that would be delivered to these two intermediary organizations. And that was a really important, again, we focused on that Michigan Association of School Nurses, but the Health Department of Northwest Michigan in terms of like the access to rural Northern Michigan communities and schools, and worked with a leadership team that comprised of school nurses and mental health professionals in kind of, I took a stab at kind of mocking up some materials, shared it with this leadership team. They provided feedback. We utilized their feedback to refine and finalize the materials to then deliver to these groups. And so this is what we landed on. We call it the Help Pain program, helping educators learn pediatric pain assessment and intervention needs. I love a good pun. And it works really well. Our acronym, I guess it's more an acronym than a pun. And we came up with an 8-hour comprehensive training on cognitive and behavioral strategies for managing pain. And I believe very strongly that even though I received a lot of intensive training, you do not need to have the level of training that I have received to deliver these strategies in a safe and effective way in the context of trusted relationships you already have with children. So I think with professionals who serve schools, and it could be a diverse array of people, can be trained to use these strategies effectively. And my job as a psychologist is not to be a gatekeeper of these skills, but to share them with people who need them so that they can help serve the kids, because there frankly are not enough psychologists or mental health providers available to address all of these needs. So I think my field needs to think about our role as consultant and educator to others in terms of sharing and disseminating some of these strategies to reach children who need them. So the goals of this project were to train the school providers, primarily nurses and also social workers, in evidence-based pediatric pain management strategies, And then to also do this with the goal of increasing access to high quality and evidence-based care for children experiencing pain. And ultimately, we aim to improve child outcomes. That's really the goal: get kids back to school, get them functioning better, and hopefully promote long-term success and resilience. And so over the 2022-2023 year, we developed this 8-hour training, and then we did it separately for the 2 intermediary organizations. So Michigan Association of School Nurses received the whole thing in a single full-day conference workshop that I delivered in person. And then the health department, they invited me to standing required meetings for their staff. And they had like day-long meetings, and I would go to 2 hours of each of those meetings. There were 4 that were spread over the course of the 2022-2023 year. And so I delivered their training in 4 2-hour increments. And so after the health department received the first training, I started doing monthly check-ins to ask them about, are you using these skills? Are they helpful? Do you have any other questions? Would you like additional support? And then we got pre and post-test questions, including qualitative interviews from people once they completed the health pain training. So the Michigan Association of School Nurses did that all in one day, and the health department kind of did a baseline assessment. And then at the end of the academic year, when they completed the training, they did their post-test questions. And so overall, we were able to reach 68 professionals serving school providers, and 27 of those were focused in the Northwest Michigan region. They were employed by the health department and served schools throughout that region. And so this is kind of a graphical map just to show you a sense of where we were able to train providers who have access to our skills. So we had a really focused training approach in Northwest Michigan, but you can see through the partnership with the Michigan Association of School Nurses, at least in the Lower Peninsula, we were able to have a pretty diverse reach of people. And we have not yet reached providers in the Upper Peninsula, which is certainly a goal in future work. And so this is kind of what the content ended up being for the 8-hour training. We provided more in-depth instruction on assessment strategies, including like what you would use for kids at different developmental levels to really understand the impact of pain on functioning. We provided more in-depth instruction on educational strategies, and I'll show you just briefly what some of these look like, but they include kind of just like a model for understanding pain, and then parent guidelines for how to support a child in managing pain, a variety of behavioral strategies, including relaxation and activity pacing, and cognitive strategies as well. And then we provided case examples and had interactive activities where people could discuss kind of hypothetical scenarios and how they might utilize these strategies to promote success for these patients. And then we talked about like tailored approaches in school settings. If someone also had co-occurring mental health concerns, for example, how one might address or triage care kind of based on that sort of additional concern a child might be faced with. And so that was kind of the general overviews. And these were some of the strategies we used, the core content. And I think what is important to note here, you'll see like a lot of it is cognitive behavioral in nature. We also had some mindfulness meditation, which is pretty synergistic with what a lot of Michigan school providers are already using for stress management. So that felt pretty comfortable for people and felt complementary to ongoing efforts already underway in schools. And the other thing that we targeted, which is really important, honestly, for probably all of us, particularly kids and kids dealing with pain, is some strategies to help promote good sleep hygiene. Schools often start really early. People are run down and tired. And if you have chronic pain and you're tired, you're likely to feel a lot worse. So we thought that was a really important part of care as well. And so I just want to show you kind of briefly, I'm going to show you a few examples of what the final training content looked like. And Michelle Adler is my project assistant. She's not on this call right now, but she had a really instrumental role in making this look really engaging and user-friendly. And so that was what we tried to aim to have a very interactive training experience. I know you guys are kind of my captive audience right now listening to me talk. I did not want to subject people to 8 hours of that. So we tried to make it fun as we possibly could for a training by doing some real world examples and having these slides. So this was how we introduced a principle we called gate control theory. And so basically what we know is that kids with pain have different thoughts and feelings that might impact their experience of pain. And it used to be thought basically that, say, like you injure yourself, that signal would just go to the brain and you would feel pain. But we know that your thoughts and feelings can actually influence how much of that pain you may perceive. And that's why different people might have the same injury, but experience it differently. And so these are really neurochemical signals, but in a simplistic way of explaining it to children, we say it's like gates. So people have multiple gates, and depending on how open or shut they are, really influences how much of that pain sensation goes up to the brain and how much they experience that pain. So different things that might keep the pain gate open, like in this example here, where the gates are open, might be things like negative thoughts or negative mood. Somebody is currently stressed out. Maybe it's a big exam or an argument with a friend. Muscle tension. We often carry around muscle tension we don't always know we even have. Like I always have tension in my shoulders. I feel like I'm often, as I get more stressed and tense, they go closer to my ears. A lot of times we don't even realize how tense we are. If we're thinking a lot about the pain, well, that opens the gates and we're kind of aware of it. It can make it feel worse. Or if someone well-meaning, like a parent, asks us about your pain, like, how's your pain feeling now? How's the pain? Well, geez, now that you mention it, it hurts. Sometimes when we're in pain, we avoid doing activities, or we might overdo it and kind of burn out. And we see these patterns in kids with chronic pain, and that can also create like a cycle of continued flared and like dysregulated activities. And then I mentioned sleep hygiene is really important, and we know not enough sleep is not good, but kids who are sleeping too much, that's not really helpful either. So those kids who go home and crash and nap for hours and then they're up for many hours of the night, that's like not a very helpful or healthy sleep pattern either. That can also contribute to increased pain. And so what we do is, this is really like a nice framework for then explaining how many of the strategies we'll teach in the program will help target some of these issues. And we talk about different examples that might close pain gates. So like having a conversation with a really good friend, it doesn't take the pain away, but it distracts you. It might help you to feel better and kind of cope with that pain better. We always make sure that kids know and that providers know to tell those kids, we appreciate your pain is very real. We don't want people to hear like, this is all in my head. We want people to hear like there are many factors that influence our immune system, and how we experience pain, and some of those we can modify with appropriate tools and influence. So this is the framework we use to kind of help with rationale for how some of the tools might help kids. And these are just some examples of some of the tools. So I talked about like the overactivity or underactivity. So we teach kids a strategy, and we teach providers a strategy to work with kids on, called activity pacing. And this gets at that both overdoing activities. So if you think of like the honors student who has chronic migraines or belly pain, you know, taking all of these AP honor classes, involved in drama or sports or like many activities, and they may just be going, and they may burn out and just have like episodes of flares related to really being overscheduled and overdoing it. Alternatively, you might see a kid with chronic pain who kind of disengages. They're not going to school very much. They're falling behind. They're not engaging with their friends because it might hurt to be physically active or socially active. So they may stay home, be on screens. And that's going to contribute to a cycle that continues to increase pain as well. So what we really try to aim to do is teach kids how to pace activities. So we know like kids who have a lot of stuff going on, kids who may not have very much going on at all, we want to work towards having a pattern where they're doing some activities, but they're building in rest and break. They're using the coping strategies that they learn in this program to help break that cycle of pain so they can do the things they need to do and want to do and not let pain get in the way of their functioning. And here's an example of a cognitive strategy. This is talking back to negative thoughts. I will say a lot of the mental health professionals I've had the privilege of working with are well-trained in cognitive behavioral strategies for anxiety or depression or management of mental health concerns. So whereas like the activity pacing skill is pretty specific to a child with chronic pain, a lot of times some of the providers we work with already have some knowledge of how to use kind of talking back to negative thoughts for mental health symptoms. So it's just adjusting it for pain management. But our nurses oftentimes do not have training in this at all. So this may be more novel content for them. And so the idea behind this is that talking back to negative thoughts can change or close those pain gates and prevent some of the pain signal from getting to the brain. And examples of this, so if a kid has negative thoughts like, I can't cope with this pain is awful, my life is awful, you can work with them to kind of generate what kinds of thoughts might be creeping in for them, and then work with them to develop realistic and productive counter thoughts, such as I'm going to be okay, I will do my best, I can ask for help. So these are some examples. We have kids like oftentimes write these down or put them on their phone so that even when they're kind of stuck in this negative thought, they can revisit these. And what we have found, research has shown that even if you don't believe the positive thoughts, by repeating them, eventually can actually change how you feel and improve your symptoms. So it can be a really kind of like with many things, practice really makes perfect. Practice can really help make the skill more effective, even if the first time a child might use it, it may not feel like it's changing their thoughts. And so that's just some examples of some of the strategies. And, you know, this is, again, a comprehensive program, 8 hours. We've just developed some really great training videos, which I'll talk a little bit about, and other examples to really make these tools come to life and really showcase how they're used. But for this initial 8-hour training, so we did them in person and in group-based formats. And then we expanded upon how we can understand provider knowledge before and after. So we developed a 20-item knowledge quiz and looked at results before and after the training, because we also still ask about self-reported knowledge, which is important, but we recognize people may feel like, oh, we want Dr. Cunningham to feel like we've learned something. We better say we've learned something. But the knowledge quiz gives us a more objective way of seeing whether or not we've actually changed people's understanding of how to address and manage pain. And then we did a qualitative interview, which was done by my program assistant, Michelle Adler. So I was not part of that. So people could hopefully feel a little bit more comfortable sharing kind of candid feedback on the feasibility, acceptability, and appropriateness of the program, which we also asked using some self-report measures. And then, as I mentioned, we got monthly data on their use of both screening tools and pain management tools that they learned. And then we had an option for people to report child outcome data as well. So I think to make programs like this sustainable, we need to think about resources that can help promote its success. And so since we have grant support, we were able to offer some participant compensation. But what we learned was with the health department, they were not able to accept compensation because this was considered part of their workday. So that was a challenge and was something I wish we could have offered. But what we were able to do for the health department and for the Michigan Association of School Nurses is offer everybody pain-focused CE credits. So they were able to earn up to 8 credits, particularly if they were a nurse or a social worker. And these are 2 disciplines who need pain-specific credits. So this was quite incentivizing. People needed these credits anyway to maintain their licensure. So we were able to give that to people. We also worked with the College of Human Medicine to develop a professional certificate program so people can say they are HELP Pain certified. And then we really developed some pretty fruitful relationships with some key community partners who received this training and then took it and made it their own. And I'll showcase some of that work here. We got some descriptive data for this first year just on how feasible the program was, the provider knowledge, and used some thematic analysis to identify some themes following the qualitative interviews. And so I want to share with you some of our results. We're currently writing this up for publication, and I'll tell you a little bit about our efforts here in year 2. We have another year of grant support to do this work. What we found was that more than 80% of people who started the HELP Pain training completed the post-assessment. And our Michigan Association of School Nurses was a captive audience. So the retention rates were good there because everyone was there. But even within the health department, we were able to retain the majority of people who completed the baseline. And all these people elected and voluntarily agreed to provide data. In terms of implementation outcomes, when we looked at some specific measures that measure the success, the vast majority of people, between 89 and 90% who participated in this program, endorsed agreeing or strongly agreeing that this program would be feasible, acceptable, and appropriate for use with the children that they serve. And so when we looked at our qualitative interview data, we found some interesting themes that arose that I'll share with you. One was involving kind of the mind-body connection. Another involved kind of taking a tailored approach to care for children who have pediatric chronic pain. And others noted some broader benefits as well. So these are some examples of some of the quotes that our providers shared after completing this training. So this person indicated you can't separate the head from the rest of the body. And interestingly, in the health department, because there was oftentimes a school nurse and a social worker who might concurrently receive the training, oftentimes they would partner together to communicate about kids. So it might be like the nurse is the first person who identifies the chronic pain issue. There were cases where they would then partner with the social worker who might do more of the actual management using the CBT strategies. But there were deviations from that as well that I'll share, which were really interesting. Others really noticed these, like the modifications of strategies. So you could use it with young children, you could use it with older, like teens, and kind of gave people some skills and some problem solving methods for how to kind of tailor it based on the needs of the kids they served. So, for example, even in a child who might be nonverbal, there are ways to adapt some of the pain assessments skills, and there's some behavioral strategies you can still use to support the needs of a child who might not be able to verbalize their pain. And what was really interesting too, and this is such a challenging year, and it continues to be, when we did this training was kind of like post-COVID, and even now, like a lot of school providers are feeling just spread extremely thin, feeling burnt out, and people notice that these tools would be beneficial not just for the students they serve, but potentially also with staff members, with their own families, and personally with some minor tweaking. And that wasn't the intended goal going in, but a really interesting theme that arose in terms of giving people access to these tools. And so this is a really compelling piece of data. So we gave that knowledge quiz prior to people starting the help pain training, the 20-item quiz, and the average score is about a 56%. And that's failing, right? Like if we think about like a paper pencil test back in school, that's someone who doesn't have kind of competency in that area if they get a score of a 56, but they're clearly not getting a 25%, which would be just guessing. They have some knowledge they can draw on, but they clearly have additional room to grow and learn. What we found after delivering the help pain training is that people scored about a 73% on that test. And that's a passing score. It's not 100%, but again, like this is an 8-hour kind of comprehensive program. So I think people might still have room to learn and grow. People might need some refresher courses or some additional consultation or support, but it really looks like they have some good foundational knowledge they can work from to immediately start providing some of these strategies to kids. So I found this result a statistically significant result, but it's a pretty meaningful result too in terms of what the change level that we see is. And similarly, we really saw a really strong self-reported increased understanding of use of these strategies, and nearly 100% of people felt like they understood and felt comfortable discussing these strategies with kids after receiving this training. So this was really powerful as well. But, you know, learning it and feeling like you know it is one thing, using it is another. So it was really important to get data on whether or not, first of all, people would continue to follow up with us, and then what we would learn from that. So over this first year, I thought this was reasonable. We found, you know, we weren't compensating people for this data. We were just asking people, you know, are you using this? How often are you using it? What are you using? What are the barriers? You know, what's helping to make it easier? And it started about like over 60%, and it did diminish a bit as time went on, but it was fairly stable. So between, you know, 40 to 60% of people provided data on use of these strategies over a 9-month period of time. And what they reported was, on average, in a given month, they saw an average of 7 students who might benefit from this program. And there was a pretty wide range there, but I think this is really important. And it underscores what we already know, that this is a common problem and that these are the providers who are tasked with addressing it. And on average, people reported using 3 of the different pediatric pain management tools that they were taught in the program to help support the needs of kids with pain. And this is just a graphic of people who used at least one pain management tool over the 9-month duration, which is really impressive. The majority of people, 60% to over 80% of providers, are using at least one strategy over a 9-month period of time, which to me is very promising. And people identified if they had access to a private space for children to practice these strategies, that really helped to facilitate the use of this. And if they were able to integrate pain assessment into their current practice patterns well. So some people, like in the health department, have an EHR, an electronic health record, where they can record some of these data. And that just helped really identify in a clear way who could benefit. Some of the barriers, unsurprisingly, is lack of time. If we think of somebody like a school nurse, they're tasked with many different responsibilities. So it can be challenging to take on like another training and doing another thing on top of an already extremely busy day. And then, of course, if a student is not interested, that really can be a challenge in terms of getting people access to this care. In terms of getting data on actual child outcomes, this was voluntary. So really, we were focused on provider outcomes for this study, but we did get 47 data points on 12 unique students from 8 different providers. We didn't have enough data to really interpret this in a meaningful way, which tells me the way that we were delivering this was probably not very practical and feasible in terms of thinking about collecting this data long term. So we've since reevaluated how we will collect data in the future from people. And I'll share a little bit about that in our kind of year 2 projects. But what we've learned is like this is probably more clunky and challenging to ask providers to get this data from students and share it with us. So we've thought about kind of briefer ways of assessing how kids are doing, or if we can leverage existing tools like attendance data, and whether or not we could leverage that to understand if this is yielding an impact on child outcomes. I do want to quickly show a couple of examples of some of the champions and the relationships I developed from doing this training, where people took this and kind of ran with it and made it their own. So one example is local to where I am here in Rockford, and the other example is actually up in northern Michigan. But Kelly Theaker is a school nurse who received the training through the Michigan Association of School Nurses, and she invited me to do a professional development day with her after getting the training. So we got together and co-created a 30-minute brief overview of select strategies, more basic strategies for what it might look like for a provider to assess pain, provide some education and some basic relaxation. And she actually was really interested in the mindful eating strategy. And so we actually delivered this to 37 school professionals in the Rockford public school system. This included teachers, athletic personnel, cafeteria staff, support staff, office assistants, or secretaries. So it was really a wide array, recognizing these kids are sitting in class. And what we learned too in doing this work is sometimes like a provider would have a kid go and practice the strategy, but then a teacher might be concerned, well, the child is missing a portion of this class. So that would be a challenge. So thinking about how to develop this in a way where everyone's on the same page, and maybe the child could practice like during a non-core class, for example. And then sometimes like the office assistant would think like the best route for a child struggling with pain is to send them home. And so we also wanted to open up the lines of communication so everyone had a shared goal. Like we're really trying to avoid sending the kid home, but if we can keep them in school and arm them with some strategies they can use to help them manage their pain, like that's really the shared goal of the team, and communicating with that with everyone is a really important step. So we co-developed it, and then the nurse actually created these posters. Kelly created these on her own. She was not compensated for this, and she posted them throughout her class. She created these QR codes so people could access recordings that we had developed to use some of these strategies. And then she took our mindful eating exercise and she actually redesigned it. So she's like, drawing from my training as a school nurse, mints are something that can be helpful for kids who have symptoms of nausea. So I'm going to structure a mindful eating activity surrounding eating a mint. And I'm going to provide mints to all of the school nurses. She was the district nurse supporting the boots on the ground. And then she even like redesigned the script in a very creative way, where it was like, pretend you're an alien invader coming to this planet. What is this thing? Is it poison, or is it maybe food? And then walk people through the mindful exercise kind of in a reimagined way. And I like her approach so much. I since have rechanged how I actually deliver this so that it reflects the script that she developed, because she really took it and made it even better. So that was really exciting. We got some data on some of the staff who completed this training. They felt it was helpful. They felt a little bit more comfortable. And again, we found a majority of people were interested to learn more. So that's one example of how somebody within the community took the program and ran with it. Another example is actually from a school nurse who's employed by the health department of Northwest Michigan. Her name is Jean, and she works in Gaylord schools. And she reached out to me and said, I have a number of these kids who are really suffering with chronic pain. They're missing a ton of school and they're not very socially connected. I want to create a group. I want to create a pain group where I can teach them these strategies together. I'm going to partner with the social worker who had also received this training. We're going to co-lead this group. Can you help us develop some content? Here's kind of the order of the skills we think we'd like to deliver based on the help pain training. So I worked with them and I scripted something so it could be very consistently delivered from year to year, provided handouts. And then the social worker felt pretty comfortable using the skills with like the help pain training and her existing knowledge of CBT. And Jean requested some additional consultation and support. So she and I met every other week. We'd go through the strategies. I would bring up some examples I could think of based on my clinical experience of different challenges that might come up, or how to kind of address kind of common sorts of approaches that would be beneficial to utilizing the skills. And she and this counselor co-delivered 6-week session using the help pain framework, 45-minute sessions with 8 students in 4th to 6th grade. And we don't have physical data. She actually did collect some data, and then somebody within the school was moving things and the data actually got lost in this move. But she anecdotally reported these were kids who were not going to school, and then they were back in school by the end of this program. So I'm interested again in thinking about ways to capture the data in a concrete way. But she felt so energized by this. She's continuing these groups. So she's starting another one this fall. And then there are 3 other nurses within the health department who have reached out who are interested in running similar groups. So we're in the process now of sharing our materials. And one thing we've changed is, in addition to getting like data on like kid pain or kid impairment, we've asked providers to provide data, like a very brief assessment on kind of where the kid is at in terms of functioning before and after, so that hopefully we can easily capture some data without having to rely on the provider asking the child to give data to then report back to our research team. And so, in recognizing working with community members, there's a level of how engaged they can be. And we started off with like, here's what I have to offer. What do you guys think? Where it's really researcher driven. And we've kind of evolved to where I really consider some of these key partners, both members of the intermediary organizations who've emerged as champions and some of the leadership team within these intermediary organizations, is really being my research partners, collaborative team members. And there can even be a future evolution where they take on more of a PI or a co-PI sort of role, where they might lead the research questions, and then I can support them with my knowledge of pediatric pain management strategies to devise research and clinical practice that would be really aligned to the needs of their community members. So this is an evolving thing that we've been doing over several years, but I'm excited to see it continue to grow. So now this is year 2. And so we're doing quarterly check-ins with people who've already received the training. We've streamlined it, and we've added, again, some simpler ways of understanding how children are functioning to just track whether or not they're still using strategies and how they might be using it and what barriers they might be faced with. We're also in the process of creating new and ongoing partnerships. So that is something that's continuing to evolve. And if anyone is hearing this and think it might be of benefit to the communities they serve, I invite you to reach out to me. I would be really excited to build this. One partnership, for example, is a nurse who received this training at Utica schools through the Michigan Association of School Nurses has reached out to me to see if I could help with a 2.5-hour training for social workers in her school district, Utica schools. So she and I are actually going to meet and go through. She will actually deliver the training as like the trusted insider, and then I will help to make sure that it's delivered in a way that is true to the content kind of in the background. Because what I have found, again, as an outsider, is I haven't built the trust with everyone. I may have built trust with some key partners, but sometimes they are really the champions who are going to make the program the most successful working within their systems versus me as an outsider. We've just created some training videos that have just been sent to our team. We recorded them last year, and we'll be using them to create asynchronous learning modules. So we're partnering with the School of Social Work to create a CE credit bearing learning module through D2L at Michigan State University. particularly for school social workers and as part of a school social worker competency program. So that's very exciting. And then we're exploring similar possibilities with the Michigan Association of School Nurses to develop a similar asynchronous learning platform. And we're really excited. We think that can really help us to continue to expand the reach of this. And if we can partner it with people being able to develop, to earn their CE credits, I think that will really go a long way in terms of promoting sustainability. I really hope to take this nationally and do large scale dissemination implementation, even internationally as well. And I'm currently doing some work with collaborators in Sweden, particularly for kids who have belly pain, and actually working within primary care settings to deliver some of these strategies to kids. And I think this needs to be thought about in a number of different ways. And like the solution of how the skills get to the kids really is going to depend on the resources of each given community. I think if we want to collect more data on how kids are doing, we need to also incentivize with grant support, youth participation, so that we can understand how they're doing, but that they're also getting something out of it as well. So I'm going to skip some of these questions because we're kind of getting low on time, but I do want to share that I recently published a commentary based on some of the lessons that I've learned in this first year of doing this work in partnership with these two underserved, these two intermediary organizations, but particularly thinking about rural northern Michigan and its lack of access to behavioral health care to traditionally support kids who are struggling with chronic pain. And so in doing that, again, it really calls on, this was published in a pediatric psychology journal, because I'm really calling on my colleagues to really reimagine their roles. So use dissemination implementation science, basically partner with community members to get the tools out there into the communities who need it. But reimagine our roles so that we're not holding onto the skills, but sharing them freely with people, which is not a new idea. It's been an ongoing area of controversy, but there's always been an active voice of psychologists who have believed this strongly, and I'm one of them. There's a real goal in partnering with intermediary organizations. I think if you already work with organizations who have relationships within communities, like that's really key versus going to individual schools. Like it can be hard to get into a school, but we were able to get into so many schools by partnering with the health department who's already embedded within schools. Of course, like working with our community champions have really helped promote and really energize the work and promote outreach and just take it to the next level. The work they do from within is so key. And then using resources to incentivize people, financial resources, CE credits helps incentivize success. So that's kind of what I wanted to share today. And I did want to really acknowledge my incredible team. There's also just a picture of my family. I acknowledge my spouse and all the help he gives me while I champion some of this work. But I have like so many incredible team members here at Michigan State University within the communities that I serve and the intermediary organizations who make this all possible, and my funding sources as well. With that, I'd like to open it up to any questions, and I provide my email here. You can always feel free to reach out to me. Be really happy to talk with anyone who would be interested in using these tools to support the needs of the kids they serve. Thank you all so much for your time.
Thank you for being here today. We appreciate it. If there's any questions, please go ahead and unmute yourself or type them in the chat. I did have one directly. It was, what about Northeast Michigan? I don't know if you had a particular reason for starting in the Northwest there, or if
yeah, I started in the Northwest, quite honestly, because of my family connections there. So that was an area where I felt like I personally, like my niece struggled with these issues and was there and didn't have access to care. So I had like some personal strong connections to that area, but it's just a starting point. I think that what we've done here is something that we can replicate while tailoring it to serve the needs of other communities. So I've recently reached out to another health department that serves other schools in northern Michigan. And so hoping that we can continue this work. And someone saying they'd love to see in the UP, I agree. I think that would be, that's a real a miss that we've had in this current iteration, is that we haven't yet reached providers directly serving the Upper Peninsula. And there's many kids there who need this support.
Definitely. Thank you. And Adrian just dropped the Qualtrics in the chat. You can go ahead and use the QR code or use the link in the chat. If you have any questions, again, I can provide you with Natasha's if you missed it. There's also my email on the screen. Any other questions?
Someone asked about the types of pain kids are having. The most common pain we see are abdominal pain, headaches and migraines, and also musculoskeletal pain, which can be widespread or specific to a region. And you can have multiple pain complaints, like belly pain and headaches often go together. Those are some of the most common, but this can be really for any pain issue, even if it's due to a disease. So I work with kids with lupus, for example, and there's some disease-related pain. These skills can be generally applicable kind of regardless of where the pain is located and what is the known cause of the pain. A lot of these kids do have comorbid anxiety or co-occurring anxiety, but not all do. But belly pain and anxiety are two things that can often go hand in hand. I have found about 50% of kids who have belly pain have clinical levels of anxiety as well. And so I've also done some work with those kids to make sure we're addressing both pain and anxiety as well for those kids who need that additional support. Somebody in the chat mentioned a challenge with clicking the link for the evaluation. I just wanted to also acknowledge and say thank you for all of the kind words that were put into the chat. I appreciate that.
The second one that was posted should work. The first one was a double.
Somehow, yeah, it like duplicated when I hit, copy paste. And I didn't see it before I hit enter. So my apologies, but I posted it and as a single link a second time. So hopefully that one's working because I do see that other people are getting in. So hopefully, oh, good. Someone said the second one did work. Thank you.
And again, I just dropped my email into the chat. It's just my first name at msu.edu. I think I paid a little bit extra to have that easy email. So please feel free to reach out if you have any questions, if this is something that sounds of interest to you. Always happy to support people, supporting kids and communities who might benefit.
Thank you so much for being here. It was great. Great research, and I'm looking forward to hearing more on what happens on, your round 2.
Yeah, it's a very exciting phase of trying to figure out how to make something sustainable beyond the life of a grant. I think that is so important. And I think the community champions are going to be the key to that.
Exactly. Thank you. All right. Well, I will go ahead and stay on and let you guys have the screen up for a minute while you're taking your evaluations. And you will have a follow-up email coming in just with general follow-up information as well as the evaluation link one more time for those of you who can't stay on. So again, thank you, Dr. Cunningham, for being here. And we look forward to having you in the future.
Wonderful. And I'm happy to stay on for a few more minutes too, in case there's any additional questions.
Perfect.
I'm going to drop the link in the chat one more time. Just give me a second. I'm going to get it